Hello, everybody, and welcome to the Eaglet Eye DirectConnect webinar with ScanFit Pro, which is made by the fine people at EyePrint Prosthetics. I'm Ted Newell. I'm a business development manager for Eaglet Eye in the United States. I'm based in Philadelphia, and so I'll be helping to host the program tonight. And we have a number of other important guests. One thing I'll just note in terms of housekeeping right now to get off for everybody just to think about is use the chat for your questions. As the meeting goes on, ask questions, and we'll get to the questions toward the end of the program. Unless we see something that's really timely, then I might interrupt and try to get an answer to your question. And I'll be admitting people as the night goes on, because people continue to join us. So again, welcome to the webinar. This will be a lot of fun. And tonight we have three guests that are very important, of course, with the EyePrint prosthetic people. We have Megan Bauer, who is a ScanFit senior consultant. Very important job. And if you are ScanFit customers, you probably have dealt with Megan in the past. So welcome to the program, Megan, and she'll be following me. And then we also have the founder and president of EyePrint Prosthetics, Dr. Christine Sint. She's a graduate at the Ohio State University College of Optometry, Buckeye fan, I hope. And after residency at the Cleveland Veterans Administration Medical Center, she joined the faculty of the University of Iowa Department of Ophthalmology and Visual Scientists, great place for research, where she is currently the director of the Contact Lens Service and professor of clinical ophthalmology. She's also a fellow of the American Academy of Optometry, a member of the American Optometric Association and their cornea and contact lens section. She's the past president of the Women of Vision and the past president and co-founder of the Scleral Lens Education Society, which many of you are probably members of, and if you're not, you should be. It's a great organization. Also with us tonight is Dr. Tiffany Andrzejewski, and she graduated with honors with a degree in biology from the Indiana University in Bloomington. Sorry, she's not a Buckeye fan, but that's okay. She studied optometry at the Illinois College of Optometry in Chicago. Afterwards, she went on to complete a postdoctoral residency in corneal and contact lens management at Indiana University, where prior to her joining the Chicago Corneal Consultants, which is where she currently practices. It's a Chicagoland area MD-OD practice, highly regarded practice. She's an American of the American Optometric Association and their cornea and contact lens section. She's also a member of the Scleral Lens Education Society and is a candidate for fellowship of the American Academy of Optometry. So you'll be hearing from them shortly. And if I can get my slides to advance, there we go. There's Christine and Tiffany. So first, let's talk a little bit about the ESP, the Eaglet Eye. Let me make sure everybody's admitted. Okay, we just had some late people join us. For those of you that just joined us, I just introduced the folks from EyePrint Prosthetics, and our medical speaker tonight is going to present case studies, and that was Megan Bauer, who's a ScanFit senior consultant, and then also I introduced Dr. Christine Sint, who's the founder of the company, and Dr. Andrzejewski. Make sure I get that right. Okay, so let's keep going. So first of all, when we think about the Eaglet Eye and the ESP, we often talk at our company about a transformation of scleral lens fitting is happening, and it really is. If you look at what we've learned about scleral lenses and the scleral and scleral lens fittings, we've learned that the shape is mostly asymmetric. It's usually irregular, quadrant specific, or toric, but rarely spheric. And we cannot predict the scleral shape by assessing the cornea, especially that cornea of irregular eyes. They just don't go together. So we need more accurate data. We need the scleral data. We don't want to extrapolate and guess. And if you have that scleral data, you have improving, and it lets more people in. You have improved fitting success, and you reduce the learning curve. And of course, with improved fitting success, you have happier patients, and you have more time in your practice. So the opportunities I talked about just a second ago, data of not only the cornea, but also the limbus and the sclera. No more guesswork. And this profilometry is the technology to efficiently fit a scleral lens. And as you can see from this image, you see everything. And that's important because not only do you see everything, but the people at ScanFitPRO see everything. So what is the ESP? We call it's advanced profilometry, but technically it's called a corneoscleral topographer. And it scans up to 20 millimeters in diameter. And we do have some practices that go bigger than that. In a single shot, you get that whole image that I just showed you a second ago. And we are capturing about 500,000 data points. And the accuracy is amazing. At the cornea, we have 2 microns of accuracy. And at the sclera, we've got 10 microns. And it's really comprehensive analysis software. So there's a lot of information that you get with this software. It's much more than the image I just showed you a second ago. And you'll see much more in terms of images shortly. But we have 14 maps, 2 calculators, and over 18 ocular parameters that you can look at. Oops, let me go back there. So this is how the instrument works. And so even we call ourselves a topographer, but we're working a little bit differently. We're not a Placido ring type of topographer. We have 1 camera and 2 light projectors. And we take an image of the eye, and because we're using reflected light, it's really important, of course, that we use fluorescein to get this image done correctly. And what we're processing is what we call a Fourier transformation. And you can see what the camera is essentially seeing over here to the right as it collects data. And from this image that you see there on the left, we end up with maps and images that look like those on the right. And you can see this is very interesting. Lots of very cool stuff going on here. And it sort of backs up what I was mentioning before, which is that the cornea does not always predict the shape of the sclera, which has a lot to do with the landing zone and how well your lenses fit and the satisfaction of the patient. And you can see a lot of things here, like you can even see a little panicula right there. But the important thing is the lab sees this, and now they can really collaborate with you in terms of how to make you the best lens possible. And it's an open platform. We're agnostic in terms of the labs we work with. Of course, the labs that work with us really closely, we get great results. And you can see we work with a lot of people, including the people that are helping us tonight with this program. So we have the DirectConnect, which is where you start with the parameters that you have found on the ESP. We have our software. You work with all those parameters. You get what you think is correct. You hit a pull down menu. You find your, the ScanFit Pro line. You select it, and now there might be a couple additional fields that show up that are directly related to them. Let some other people in. So you see those parameters, and then there's a button there that's DirectConnect to EyePrint Prosthetics. You click on that, and their order form comes up. so nicely. You can make comments, make any other changes you need to their order form. And when you send that in, it goes directly to the lab with the images. And that's how DirectConnect works. So it saves you some time, and it's really helpful for the lab. So with that, I'm going to not turn it over to Dr. Sint, but I'm going to turn it over to Megan. So I'm going to unshare my screen, and Megan, I'm going to let you take over.
So my name is Megan. I work with ScanFit under EyePrint prosthetics. So we're just going to kind of give you an overview of our software here and how easy it is to use. And then we'll go into some case studies with Dr. Andrzejewski. So what are our driving forces for fitting contact lenses in 2022? Well, we want to be able to fit all the different patient-specific ocular shapes that show up in our clinics. We want to be able to provide them with advanced optics for their visionary needs. And then on our end, we want to be able to save chair time for the patient and for the doctor. So at ScanFit Pro, we do this by receiving a capture of your Eaglet data. Again, like Ted mentioned, you just click the first lens fit, and then under your DirectConnect button, you choose ScanFit Pro as a supplier, and it will automatically export the point cloud from Eaglet into our ScanFit software. At that point, you have a couple different choices. If you want to be more hands-on with your lens design, we do allow you to design your own lens and submit it to our orders website, where a senior consultant will review your design before submitting it to the lab. Or you could just send us your raw data that you captured, and we can just go ahead and design that lens for you. And then we send the lens back to you, and you fit your happy patient. So with that, I'm going to give it over to Dr. Sint to talk about the methodology of ScanFit Pro.
All right, so let's talk a little bit about how ScanFit and how our software is a little bit different than some other products or some other lenses that you've used out there. And in order to understand that, we need to understand the data that we're getting and how we move forward with that data. So EyePrint, whether you're talking ScanFit or whether you're talking about the impression products, we use something called a points cloud. And what a points cloud are lots of these little tiny triangles, and everywhere where one of these triangular lines intersects is a point. So earlier, Ted was talking about the number of points generated. And really what we are talking about when we say that is all these little tiny points that you see here. So the more number of points that are generated, the smaller the little triangles are. So rather than creating a lens through, say, a spline system where you're creating a series of curves in different parts of the lens and you pull a curve up or down, or you change that area and it goes up or down, we are literally adjusting every one of these points on the lens. So you pull one point up and you have a cascade of events of all these other points that follow. So the more number of points you have, the more precise a change in one of those points will be. So the fewer points, the bigger the triangles, the smaller the more number of points, the smaller the triangles, and the increased ability you have to make very tiny changes. Okay. Next slide. All right. And so this is how we create these very unique, very bumpy designs that on the lens, because every single point on the ocular surface actually matters to the lens that we're designing. So with the ScanFit design, we plot out the limbus shape. So your lens is going to, your optics, your lens, your landing area is going to be the same shape as the patient's limbus. We know people are not round. Right? We can bump or anti-bump any particular area. You can literally just take a picture of the eye, circle an area and say, I want that to be higher, I want that to be lower. And those particular places, just that area can change on the lens. It doesn't have a cascade effect. So you can bump or anti-bump, but it then does not change any other curve or any other point on that lens. Because it's a points file, we can move the optics around. So we can move the optics to different places on the lens. We can line the optics up with the line of sight. And this is very important when you think about doing multifocals, for example, or when we, maybe down the road, we're going to be talking about higher order aberrations, which we don't do right now, but we will be talking about that in the future. We can actually do a bitoric optic zone, right? So if you have places where you're concerned, like, oh, I have too much elevation here or not enough elevation here, our diameters are unrestricted. People will say, well, what's your diameter? Well, it's going to depend on the size of the limbus. So you can pick whatever diameter you want. It's not a set diameter. And we can also put fenestrations in the lens. So you say we want a fenestration in the haptic, you want a fenestration in the optic. We can easily add those into the design for you to create a different fitting profile. Okay. Now, a standard periphery, these are all the same eye, same day, different lens designs. When we were restricted to, say, a spherical periphery, you get these impingement points because we know that the eye is not round. But then even when we start doing toric peripheries or even quad specific peripheries, we still can end up with focal areas of impingement, and this changes the farther away you get from the limbus. So while you may have an impingement closer to the limbus, you could have lift or more impingement farther away from the limbus, and they're not necessarily predictable one to the other. And then with elevation specific technology, you can literally circle the area you want more vault over. If you've got a little bumpy part there, you can just circle the area and you will create more lift or less lift over that specific area that you circle. Okay. Now, what this is showing us here is two things. One, the limbus is not round, nor is the limbus planar. So it's not a flat plane. The limbus is also elevation specific. The limbus has these different points. And so with EyePrint, we don't have an optic zone that is planar. We don't have the central button of the scleral lens, which sits on a plane. It is going to follow the shape of that limbus, which means that we can then align that limbus, and you're going to have less overvaulting or undervaulting. You're not going to land on the cornea. You're not going to land too far away from the cornea. You get to choose where you land, and the software designs that lens in 3D space so that the lens itself is not going to be planar. Now, the image on the left, what this is showing you is that the red line there is the limbus, and the farther away you get from the limbus, the less predictable the sclera is going to be. So, Ted showed some nice statistics earlier that said, how many are quad specific and toric and all those kind of things. But the reality is it's going to depend where you're measuring from. So you could say at the limbus, you're going to have so much toricity, but a millimeter out, 3 millimeters out, 5 millimeters out from the limbus, your toricity changes absolutely completely. So even if you're measuring a millimeter out, you could say, well, this is a quad specific eye. But if you're measuring that 3 millimeters out, you could potentially have a very irregular cornea. So when we're talking about the regularity of the eye, we really need to be talking about how far away from the limbus we are talking about, and not just looking at it as a bigger picture. Next. Okay. Now, by looking at a lot of eyes, and I mean thousands of eyes, what we find is that the average cornea is about 12.5 millimeters horizontally, but only about 11.5 millimeters vertically. That meaning the average eye is going to have more than 1 millimeter difference horizontal to vertical. And when you use the Eaglet and ScanFit Pro, it picks that up and it will create your lens to be to matching that horizontal versus vertical, so you don't end up with those mismatch areas over the limbus. The software can move the optics around as well, and that can really help with fitting, help with areas so you can get away with touch on the back. And again, you can change those optics around without changing the overall fit. So you can move the optics, you're still going to be aligned in the limbus, you're still going to be aligned in the periphery, vaulting any pinguiculas or any irregularities that the machine picked up. Next slide. Very good. So Megan, are you doing this one or am I?
Sure.
Okay.
Yeah, so why ScanFit Pro? So just building off everything that Dr. Sint just went over, we have an easy export system with the Eaglet DirectConnect, exports straight into the software that you can then submit or just send to a consultant. It really just takes minutes to design the lens. Most of our software pages, you'll kind of see a little taste here in a second, has a software generated default, but then also allows you the ability to override that as a practitioner if you want to be more hands-on in your design. So again, that applies to the limbal shape here. So we have that software generated limbal shape, again, in our hyperbolic paraboloid 3D non-oval shape that Dr. Sint was talking about earlier, or you can then adjust those specific points yourself. It shows real-time changes in your lens when you adjust the lens parameter, so you can see the adjustments you're making and how it doesn't affect the overall fit of the other parameters of the lens. Again, like the slide before, we can decenter the optics. We can go up to 200 microns in any direction. Again, software generated. It detects the apex of your cornea based on the Eaglet data, or again, you can override that as a practitioner. Easy power calculations. So, throwing a trial lens on your patient and inputting the known base curve and power into our calculator. We'll take the generated base curve into consideration and calculate your new power. So no mental math there on your end. We do have the multifocal add-on option here as well as the fenestrations. And then again, I'll show you a little taste here a little bit later on in the presentation. We can bump and negative bump over user-defined haptic or areas of the haptic. So like Dr. Sint said, you can circle a portion, define a specific area on the haptic of that lens, and keeping that elevation specific shape, it'll just you can either raise the clearance on there to add, say 100 microns more if you're getting impingement, or if you have, you're getting fluorescein under the lens there, we can tighten that by, inputting a negative number there. So I have just a short video here. Like I mentioned before, this is going to be our limbal plotting page. Again, software defined limbus. You can clear that out. Sorry, the mouse in the video is a little bit uncalibrated. So this is just, plotting your own limbal points. If you need to make adjustments in the limbal area after, you say you get the first fit lens on there, we can move these specific points, again, not defined by or constricted to a single quadrant per se. If we need to just pull up that inferior limbus a little bit, if you're getting, some conj underneath, we can just move those limbal points up. Again, not affecting the rest of the fit of the lens. Okay. And then here, this is, being able to see these parameter changes in real time. So here we have a pretty steep cone. Again, this is a great Eaglet scan here. They were able to capture a lot of data. We can see we're a little bit short on clearance in that central area, and then we've got some excess in the mid-periphery or boundary area. So on the left there, I just increased the central clearance and decreased the boundary clearance. And we can see that change happen in real time, and the clearance becomes a lot more even. And then you can rotate, the scan around in the 3D space to really get a good idea of what that fit is going to look like on the eye. So with that, I will hand it over to Dr. Andrzejewski to talk about the patients.
There we go. I think we are good to go. Okay. So as we know, as practitioners and doctors, when it comes to scleral lens designs, we have three main categories. We have our standard designs and our fitting sets, which are semi-customizable within certain parameters that the lab will allow us. And that gets us pretty far for a lot of patients. We also have freeform designs using corneal scleral imaging, such like the ScanFit Pro. And there are several other options out there where we have this fully customizable option, and we're no longer intuitively hypothesizing the shape of the eye, because now, thanks to profilometry, we have an idea going into the fitting of what this ocular shape looks like. And we can design a lens off that to meet the patient's shape of the eye better to enhance our outcomes. And then the third option, as Dr. Sint mentioned, is the impression designs, which are coming from a mold. And those are going to have much more data points to be more precise. And that's where we're going to reach for something like that for our much more extreme contours, such as patients who have blebs and who have all sorts of weird shapes to their eyes. And, this is thinking of, kind of your surgical type patients, not your average or regular cornea patients. Ultimately, when we're considering a freeform lens or using profilometry to help guide our fitting, and we're talking about using these freeform designs, there are many reasons why we might do that. The biggest thing that is nice to have profilometry for is to really see with our own eyes what the scleral shape looks like, what that limbus shape looks like, instead of throwing on a lens and say, oh, this looks really bad. So it gives us a forefront on the up front of what we're getting into. And so if we're seeing that there's a lot of scleral asymmetry, we can then choose a design that better matches and allows us to help the patient have a more comfortable lens. We're also using this information to help with rotational stability. As Dr. Smith mentioned, complex optics are a real thing in this world. Our irregular cornea patients are no longer happy with, subpar vision. They're wanting better and better. They're wanting multifocals. They're wanting us to be able to correct their higher order aberrations and the glare and flare and coma. And centration and having a really good fitting lens that is very stable in the eye is going to be the key to doing all of this and providing these options and better vision for our patients. Of course, we know that there are local elevations, whether it's blebs, other conjunctival abnormalities such as pinguiculas, which everybody seems to have these days when you're fitting scleral lenses. We don't want the lenses impinging on those areas. It causes patient discomfort, and no patient wants to walk around with red eyes and the cosmetic issues that can cause. Many patients, as Dr. Smith mentioned, they have unusual corneal shapes. The more I measure HVID versus VVID, you will honestly see that disconnect, and that disconnect can really get in the way of our fitting and cause conjunctival prolapse, can cause midday fogging, because the haptic looks great, but if we're not aligning the limbus, we're still going to have fitting issues. And so having this information and this knowledge ahead of time can really open up our eyes as practitioners to meet our patients' needs and address these issues before they can become issues. A lot of reasons why sometimes in this day and age, in the post-COVID era, or still COVID era, that we reach for some of these designs is because of not only the patient's schedule, but the practitioner schedule. Patients are done coming back and forth to our office time and time again. They want to see, they want a comfortable lens, and they want it tomorrow. And so that's hard to do when we have these complex shaped eyes and patient demands to meet that. Never mind, patients oftentimes travel all over. Sometimes coming to our office is not, easy. Some patients drive an hour or longer away. And so being able to get to that final endpoint for the patient and for us is, very, very valuable. Not to mention you have some personality types where patients, like I said, they're done waiting. They want everything precise. And we live in a very technologically driven world. And so now we have those options to use technology, and that really appeases to a lot of patients. And then, there comes to cost and lab versatility and consultation. And that's where, a lot of these companies do offer this, but especially EyePrint prosthetics with these custom lenses. So the slide that you're going to see here is kind of a nomogram put together by Eaglet to kind of help you figure out, okay, how do I use this data to make some decisions? This is nowhere near, set in stone, because different lenses have different cords lengths and things like that. But if you're just looking at the general image and you want to have an idea as a practitioner of what's irregular and what's not, because it's not always obvious to somebody who's new at using the Eaglet or using the software, this can be a really, really great guide. So usually at about 13 millimeter cord length, that gets us just past the limbus where the lens is starting to come down. And so if we look at that area and we compare the 90-degree max sag difference to the min sag difference in that area, it can give us an idea if we potentially can get away with a spherical transition zone, or if we need a toric transition zone around the limbus. As Dr. Smith mentioned, that oftentimes with that limbus being shorter, if we're dealing with a really toric limbus, we might end up with a lens that, if it's landing evenly on all sides, we might end up with overvault in a certain meridian, which can cause problems. So using and looking at that cord length can be very valuable. Using the 15 millimeter cord length and looking at the difference of the T sag versus the N sag can give us an idea of how that scleral shape is nasal versus temporal. We know the nasal side is always flatter than the temporal side, which is why a lot of our scleral lenses decenter temporally or inferior-temporally. So having an idea of where things, that difference in at that chord length can give us an idea of, are we going to have issues with decentration if we don't take into account that difference on this eye? So the rule of thumb is that if at that 15 millimeter chord length, you have 400 microns of difference between those two areas, you might need to consider going quad specific in that haptic, or needing a more customized lens so that you can have better centration, which helps with the optics of the lens. And then lastly, looking at that max sag versus min sag difference again at the final chord length of that lens, whatever lens diameter you're choosing, can give you an open eye again, as if you can use a spherical haptic versus a toric haptic, which we know, thanks to the scleral shape studies, using a spherical haptic is very uncommon. But even with all this taking into consideration, we can use, freeform designs to meet all of these needs, plus use the Eaglet to help us decide what design might be best for the patient if we're not taking into account other, parameters that the patient is putting on this situation as well. So, this kind of goes into that difference between the nasal and temporal sag here, that we see that nasal side is flatter. And so a lot of times, if that lens is not fitting optimally in those different quadrants, we're going to see that lens is going to shift. And as that shifts, that's going to affect our optics. That can be really, really important if you're considering doing a scleral multifocal. That's going to be super important if you're ever considering eventually doing any sort of higher order aberration correction. But the one thing that we do see is that if a lens centers really well, sometimes the patient can get a little bit better acuity. I have seen some of my patients that I have taken from a commercial standard design and done a more custom freeform lens, and all of a sudden these patients are noticing less distortion in their vision. They're maybe getting a better line of acuity. So just aligning the lens and the optics on the eye better can help. So going through a couple cases here tonight to kind of show you what this technology can do and how you can use it for the patients can be very, very valuable. So we're going to go over about 3 to 4 cases with the time we have left. My first case is, kind of this time of year always brings at least one of these patients out of the woodwork. Is a patient that comes in and is like, I need lenses today. I leave for college in 1 to 2 months. And they really think that, oh my God, like I've got to see now. I've had all summer, but college is around the corner, school's around the corner. I need this lens tomorrow. And we all know with, our standard scleral fitting sets that it doesn't quite work that way. And so, with this patient, it was a young man who was in his 20s, came in, was seeing 2400 in his right eye with glasses, 20/20 in the left. He did have a history of previous scleral lens wear in his right eye, but that lens was 3 years old. And after he had cross-linking with my practice 6 months prior, the lens was never comfortable again. Ultimately, he came in, brought that lens with for us to take a look. Even though we hadn't been wearing it and only been wearing a soft lens in his left eye to function, we saw that he saw 20/70, but an overrefraction showed that we could get about 20/50 acuity. So there was room for improvement, not only to his vision of what he had been experiencing, but also potentially the fit. What we see here looking at the maps here is the area on the left is what you would see using the Eaglet and using the quad map. So here in the upper left-hand corner, we have the source that kind of shows you how good of a big image we got. Were we able to pull those lids away? Were we able to get the instrument aligned? And then we're going to look at the tangent angles to see if we see any weird abnormalities out through here that indicates that there might be dryness, and that can affect the quality of our data. So we know that garbage in is going to equal garbage out. And then we have the option to use this as a corneal topographer. So, it gives us very detailed information, as Ted mentioned, down to 2 microns of corneal data. And then we also have the bisphere elevation map, which is combining not only the corneal data, but also the scleral data as well. And so this big image on the right is kind of what you're going to see looking at the bisphere elevation map. This red ring is going to be the cornea itself and the limbus, but everything outside this first red ring is all scleral data. When you're using the map in real time, you can move your mouse over to and cursor to kind of see how much data you have, elevation points, things like that, to really assess this symmetry. That also gives you some good information here about HVID, VVID, your SIMKs and things like that that you're used to with the topography. So for those of you that are on the call tonight that may have never seen this information, this kind of goes over a brief overview of kind of what you see once you capture an image. So the question is, how do we use this data for this patient's right eye? So again, I went back to using kind of that nomogram of just an average lens at a 13mm chord length. We're seeing there's 190 microns of difference in toricity here. And we are seeing, as we go to further chord lengths of 15 and 17mm, we are seeing an increase in toricity. And so we're going to want to keep that in mind when we're choosing a lens for this patient. In addition, when I'm looking at the difference between the nasal and temporal sagittal depths of the sclera, I am seeing that we've got more than that 400 microns of difference down at the edge of the lens, but we're just inside that at that 15mm chord, which means you might be able to go either way, but again, you might need something a little bit more quadrant specific. And we are seeing that there is some asymmetry here, especially with this spot here. He did not have a pinguecula or anything there. So immediately looking at this image, I say, you know what, there's definitely some toricity. There's definitely some potential here looking at that 15 and 17mm chord length that this lens may decenter. And ultimately, this is a patient that wants a very fast outcome. So it just seemed to be a no-brainer trying to utilize technology to fit the lens better to maximize the comfort of his lens. And maybe if we get a win-win, maybe also the optics. And so for this patient, it was a very, very easy sell. He was on board, and with him being young, he loved the idea of using technology and not going through that diagnostic fitting process like he had before. So here's kind of the pull-in of the software, as Megan gave us a brief summary of what then things look like as we imported it into the ScanFit software. And we started by designing the limbus. And you can see here, as Dr. Simp mentioned, you know, this limbus is a little oval. And so sometimes if we're not aligning the limbus, that can certainly affect patient comfort in midday fogging. And then here we have kind of how the software will look with that lens and the final product. So that's all great and well, but how did this actually perform? So this was a patient that was literally 1 or 2 lenses and done. So we met his needs in record time and got him off to college with better vision and impeccable comfort. His mother came to the final appointment and was in tears because she was so excited that her son could see out of both eyes again, was not getting headaches anymore, and his right eye wasn't looking red anymore. And so you can see in these OCT images how that very first lens just perfectly aligns with his sclera and conjunctiva in all 4 major meridians. Now, in the first lens that we did do, I let him wear it for a month right before he went back to college. We rechecked the sagittal depth and just how things had settled over time. And all we literally made a change to was the sagittal depth. And I mailed that lens to him while he was in college, and everything's been great. He's now been wearing this lens for 2 years. So it really shows you how you can really expedite that fitting process and utilize your chair time to get to that final endpoint so much faster. And so this is what that final sagittal depth looks like. And this was when I saw him just last month before he headed back to his junior year for college. So case number 2. This is a patient of mine that's actually been wearing scleral lenses for quite some time. And you gotta love that, you know, she comes in at the end of the year. It was literally in the middle of December, and she says, my right lens broke and I'm getting ready to go out of the country for work. I need something better. And, you know, I have been noticing I've been getting some redness with my right lens. What can we do, and how quick can I get a lens? So you gotta love that things like this never happen at the most opportune time. But what I want you to take a specific look at the very bottom here is her old scleral lens parameters. Her old scleral lens took a lot of work for us to fit. We have a toric limbus, and we also have a very toric sclera. And she had been doing well, but she's still complaining of some cosmesis and redness issues with this right eye. So ultimately, to get to that endpoint faster, we went ahead and we used profilometry to help us, which I didn't have 5 years prior when we first fit her in scleral lenses. The one thing that is nice about the current upgrade of the Eaglet software is it will give you this automatic measurement of HVID versus VVID, so you can see how much offset there is and whether or not you need to go with a more custom design. And so it makes it very, very easy to see these little changes. And we know that this limbal shape, as Dr. Sint mentioned, can really impact or should impact and play a bigger role in our scleral lens design, so that we're either landing evenly on all sides of that limbus, or we're making the lens to match the shape of the eye better. And so in doing that, we're going to make sure that, we're not encroaching on the limbus at 3 and 9, and we're not getting the overvault at 12 and 6. And by aligning with that limbus, it can help with centration as well, as we previously mentioned. And so, Dr. Sint mentioned her study through looking at all the data for EyePrint, but there is actually another study out there that shows that, there is that disconnect between the HVID and VVID. And so getting that landing zone correct over the limbus can really make or break some of these fits if you just can't get rid of midday fogging and or conjunctival or limbal hyperemia, no matter what the haptics look like, because the haptics can look great if you're not aligning the limbus. And so because this design really focuses at its heart and basis off of the limbus and designing the lens from the inside out, you can be successful with this software. And so again, we looked at the different cord lengths to see what we had going on. And we do see that at that 13 millimeter cord length, she does have a good bit of toricity in her limbus, which makes sense of the lens we had her in. We are seeing that at 15 millimeters, we're not above that 400 microns here to potentially need a quad SIM design. And so, the question is, are we going to have issues with centration? We may not at 15, but if we make a bigger lens, we certainly know that we might run into that the further we get away from the limbus. And so keeping that in mind, it made sense also with her time requirements to consider and do a ScanFit Pro lens for her. Again, this is kind of what things look like coming through the software of designing her, the circular limbus. We have the back surface of the lens here, and then designing the front surface over it. And so in doing these fits and using these lenses, a lot of times you will have a one lens and done situation or just need to adjust the sag. But let's face it, eyeballs are squishy. That doesn't always happen. And so sometimes you need to be able to troubleshoot your fit to get things just right. And so the nice thing about the software, whether you're doing it yourself as a practitioner or you're sending pictures such as these to consultation and telling them the problems you're having so they can physically see what's going on, it is very easy to fix because you're not going to throw off one different aspect of the lens, as Dr. Sint mentioned, because of the fact that this is elevation-specific technology. So, for example, in her very first lens, things looked pretty good. That air bubble was actually caused by me, not her. But you can kind of see we're a little shy on the limbal clearance here. This isn't exactly how her limbus looked, but she did have some staining right there in that area of the limbus. And so we said, hey, we want to go ahead and fix that. So Megan, if you were, my consultant and I wasn't going to change this in the software, what would you do to change and fix this? And how easy is that?
Oh, absolutely. It probably would take 30 seconds, maybe a little bit more just to make sure we have all the measurements correct. But like that first video I showed you with the limbal plotting, we have that blue limbal ring with those red dots. What we would do is, kind of remove the red dots in that region. So from the image here, about 11 o'clock to 3 o'clock, and we would simply move them out, let's say 500 microns. And so we can make that adjustment. We can measure it in the software to make sure we're adjusting it at the correct distance. Again, that's not going to affect the rest of the limbal shape on the fit, but we can help improve that area and move out where that limbal clearance is measured.
Exactly. So the nice thing is, with certain lens designs, if you want more limbal clearance, you're going to get more limbal clearance elsewhere. Well, I don't want more limbal clearance here. That's how we get prolapse and issues. So the nice thing is with the software, you can really troubleshoot the areas you need to address and address only those areas. Similarly, in her first lens, we also needed to make a slight adjustment as she was getting some redness and some injection in this area at the end of the day. And so she was getting a little bit of congestion here in the conjunctiva, a little bit of conjunctival hyperemia and staining. This is kind of analogous to corneal GP 3 and 9 staining. And so we were very easily able to adjust that in the software by troubleshooting using, the bump software, where you can literally kind of draw this out and adjust that. So Megan, can you kind of tell us a little bit more about that here?
Yeah, absolutely. So again, this is a real-time video of, and this would be how long it would take a consultant to make this revision adjustment for you. So all we do is reference the scan to your picture or your request. We can click new bump, and again, the practitioner can do this as well. And you just outline the exact area of the haptic that you want to increase the clearance on. Again, we're not just going to vault the whole thing. We're going to take that elevation that's currently there and just increase it. So we get a nice little pop-up box here that allows you to adjust that vertical clearance. So if you want 100 microns, if you want 200 microns, etc. And then we can adjust that bump transition zone. So kind of, the more clearance we add into it, the larger that horizontal transition zone we want to be, just to make a smooth bump there. And so we can see in real time that that surface of the lens there vaulted up over the impingement that we were having.
So this is a patient that was referred for me internally in my practice. This patient was wearing piggyback, small diameter gas perms, as you can see here. So a rose K2 in the right eye, a comfort cone in the left, piggybacked with Acuvita. Really advanced cone in that right eye more so than the left, and just was having extreme discomfort and even having apical staining on his cones despite the piggyback. And after multiple adjustments by my colleague who was, taking care of him, they just could not enhance his comfort. And so, in seeing him for a scleral consultation here, the first thing I noticed, anything else, is massive pingueculas on either side of this right eye, as you can see here. What's also interesting is his corneal ectasia. He had a very, very small LASIK flap. So we kind of had epi-LASIK. And so we did scleral topographies or profilometry with the Eaglet on him. The image on your left is the right eye, and the image on the right is the left eye. So seeing, kind of how there is a little bit more uniformity on the left eye, with the exception of only one pinguecula, we ultimately decided to keep costs down, and we went the route of diagnostic fitting on that left eye. And he actually saw my cornea and contact lens resident to take over the case and kind of learn how to use profilometry in guiding a diagnostic fit. Versus the left eye, as we can see, has a little bit more asymmetry. We've got two very, very large pingueculas, and he has the more advanced case of ectasia in that eye. And so we actually went the route of ScanFit with that eye, given just how big his pingueculas were. And what's really, really interesting is, as Megan and Dr. Smith mentioned, the software really takes into account all the lumps and bumps. So as far as those pingueculas, there was nothing I needed to do as a practitioner because the software took care of it, versus that one patient I showed you for troubleshooting. And what's even more interesting is this is how that very first lens looked. There is no way in my right mind, doing a diagnostic fitting, I could get a lens to fit this well on the very first try. That's just not realistic. Everything looked beautiful over the pingueculas. Our very first lens, we had a little bit shallow vault, so we didn't quite dispense this lens. He had a really squishy eye, and it settled, too much just in the 30 minutes or 45 minutes he had it on in office. But it was a very easy fix to adjust the sagittal depth. And that's kind of the nice thing, and I think what all of us practitioners can agree on is the hardest thing about fitting sclerals is aligning to the sclera. I mean, we can see if we vaulted the cornea, that's not hard, but it's really getting that alignment on the sclera that really, really matters for patient success and comfort. And so ultimately, this is what his final lens looks like. And he is still to this day wearing this lens. And I last saw him 4 months ago, and he's had the lens for 2 years and absolutely doing beautifully. And what's also interesting with this is we were able to improve his visual acuity from 2100 in his piggyback gas perms to 2050 in a scleral. And so at that point, we were able to push off the need for a cornea transplant, which can definitely, change this patient's life, at least in the short run, to get him back functioning and seeing and working, which is really awesome. And last case, kind of going into the questions that were being asked when I first logged back on, was about sagittal depth and how long do you have to have patients out of the lens? And I find that this is a really great case for that. So this was a patient of mine that had been wearing corneal gas perms for many, many years. And then all of a sudden she was having a lot of allergy issues, GPC issues, sent her to an allergist. And you gotta love when your keratoconus patient comes back being allergic to methacrylate. I'm like, you've got to be kidding me. You are allergic to the plastic that your lenses are made out of. So we took a year and we just hydropegged the lenses, and that seemed to help. But no matter what, that right eye was just never comfortable. She was always getting lots of mucus and irritation. And so I finally convinced her to let me fit her in a scleral. And I knew that she was not going to have a lot of patience with the refitting process. She was kind of fed up with her right eye and not being able to see well, not being able to wear a lens well, and wearing only one less lens and that sort of thing. So I said, you know what, let's use profilometry. Let's use ScanFit on you. Let's see how this goes. And so luckily I convinced her. She stayed out of the lenses for 72 hours. So basically she stopped wearing them on a Friday, didn't have to work on Friday. And so I saw her first thing on a Monday morning. And we got pretty decent images. I mean, we can see that there's, some issues with the data maybe right up through here, but that was still about 8 millimeters of data. So I said, at least with that, I can, get a pretty good lens. And so the real good thing that you want to look at when you're looking at the data, and yes, you want as big of a scan as you can get, but sometimes depending on their fissure width, and sometimes if they have really deep set eyes, sometimes it can be really challenging to get that really far data. And so the big thing is, if you can't get tons of data, you want to get what the data you have to be really, really good. And so that's where we did kind of luck out on her, in that we had about 16 millimeters of really good data. And so, anything past 16 millimeters got a little iffy as far as looking at these different chord lengths in the software. And then we know at that point it's going to start extrapolating. So our first lens, we tried for that 16 millimeters, knowing that she had a little bit of some difference in her nasal versus temporal sagittal depth on the sclera out here. And that didn't quite work because, as you can see here in the software, that lens that we did design, we had some extrapolation. And this was kind of one of the very first ScanFits I did. So we didn't quite know how that worked. So we actually ended up designing a second lens, which brought it down to 15.5 millimeters. And because we were within the area of the scan and had perfect data, no extrapolation, everything actually worked really, really great. The one thing that I would recommend you do when you're designing lenses, not only using profilometry and using ScanFit, but also keeping in mind she had been wearing corneal gas perms for many, 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 many years. So when we designed this lens, we automatically added 200 microns of extra sagittal depth than what the software usually recommends. And so you can see these OCT images on your left-hand side. That is 2 weeks after wearing the scleral lens. And that was wearing the one that we kind of had, the right data for. I had her wear that for a month more, and she came back and we were down to 133 microns. So you want to keep in mind what your patients are wearing before you're transitioning them into scleral lenses. and not only, looking at, are they an existing scleral lens wearer or soft lens wearer to do, a short washout so you can get good accurate data, but it's also considering that, if you're taking somebody out of corneal gas perms, there is always going to be corneal rebounding. And so the nice thing is, you can, in the software, if you're doing this yourself, you can plan ahead, but if not, share that with consultation that's designing the lens. Let them know what's going on and let them know your thought process of, hey, I want you to add in some extra sagittal depth on, these cases that you're taking into a scleral lens potentially for the first time. And so that kind of picks up the cases. If there are any other questions.
Yeah, I was going to say that RC asked that second question. Christine was somewhat addressing that, but sometimes it's difficult to get a good scan, especially if the patient is unable to open their eyes. Would it be beneficial to send in multiple scans with slightly different positions of gaze?
Yeah, so I could take that one. We run into this more often than not. So some of the things we recommend is having multiple people helping out with the scan if you can. Having the patient help hold their lid, having a tech help hold that upper lid. We recommend taking as many scans as your patient lets you. Once you get the fluorescein on and all the wetting drops, etc. Taking 3 scans at once, just right away before evaluating any of them. So that's a helpful tip that we recommend. And then after that, sending those scans, all of them, to your designer, so that we can pick the best one for you, and the best one that's going to have the best extrapolation, like Dr. Andrzejewski was talking about. Unfortunately, we don't stitch any of the scans together anymore, because the cornea is a lot more unpredictable the further out you get. So it's hard to stitch that together. We don't get as accurate of a fit. But the extrapolation we have with the software, if you get a smaller scan, but you get that really good data and that quality data, we can extrapolate from there and get a pretty good fit. So
one other thing that can help if a patient has difficulty holding open their eyes is just using anesthetic. I find that can make a really big difference to, make them less uncomfortable, especially patients that sometimes have dry eyes are the ones that are needing these scleral lenses. So, using anesthetic, giving them a break, using preservative-free tears can really help them get through that image acquisition process.
Mm-hmm. Also, anesthetic in both eyes.
Yes.
Even if you're doing one eye, anesthetic in the other eye too, just so they can fight that.
Yeah.
Mm-hmm. One of the process that I've personally gone through with going from, because I've been trial lens fitting scleral lenses since the late 1990s, right? So I have put a lot of trial lenses on patients and over the years. And really, as we transition to this concept of 3D fitting and profilometry, some people, even Tiffany made the comment earlier about, trial lens fitting and using a less expensive lens. The question really comes down to, and I think everybody needs to ask themselves, because this is something I've asked myself a lot over the years, is there's a certain cost to fitting scleral lenses. And if the patient's not paying it, you are. Right. So when you're doing trial lens fitting, it's going to take more of your chair time. And that is a process that is expensive to you, right? The chair time is expensive and the patient's not paying the extra cost in that. So really, and even to the patient and the number of visits that have to come back and the number of, there's an emotional expense and there's a chair time expense and there's a gas expense and there's a time out of work expense. And so looking at the bigger picture, not just the cost of the lens, but the expense to the person, to you, to your staff, is something that everybody should take into consideration, really about how much you want to do trial lens fitting and how much profilometry it speeds you up, because you have to look at all the expenses, not just the cost of the lens.
Okay, we have another question here from Chap Leffingwell. I've been using saline with fluorescein before ESP scans. Should I be using something different, artificial tear or different viscosity? Of a different viscosity?
Well, so for me personally, when I've been doing a lot of clinical studies and looking at this, and perhaps the Eaglet people can can chime in on this. You don't want to use something that's super viscous because you're actually triangulating the raster system actually triangulates the fluorescein, right? And so if you end up with something super viscous, you will actually see little tears or little puddles in your topography, and it will look like elevations, and your lens will come up with elevations that's perhaps not in there. And so you want to use something that's going to stay on the eye, but not something that's super viscous. And also make sure, have the patient do a nice full blink and open the eye, because if they do a little flutter blink or a little half blink, the prow line, right, the tear line will actually pool up and come back up, and you'll get that tear line in your scan as well. So you want to use something that's maybe a little bit more viscous, maybe like an ocular lubricant, but not a gel.
Yeah, we concur with that completely. Our research shows that, well, as mentioned before, anesthetics really does a wonderful job stabilizing the tear film. And then any drop containing hyaluronic acid, and that can be Blink, or there's several brands that take that and that have that as a component. And so any drop, so not saline for sure, but any drop containing hyaluronic acid also stabilizes the tear film. And remember that before you make the measurement, the patient will have plenty of time to blink a few times. So, you know, whatever you've put on there will have been dispersed, will have been spread out by the pressure of the eyelids, and that is generally what we recommend their users.
Which I think also, Arnie, I find that if you do send several images, take several images and send several images, that's helpful, because our consultants can look at it and go, was that a little piece of schmutz in the tears, or was that actually there? And so by comparing images, we can say, this is real or this is not real.
Absolutely. You know, always with a single dose of fluorescein, you should be able to take 3 measurements easily. And so, and you know, some patients with severe dry eye or other complications, you might need to take a second or sometimes even a third dose of fluorescein, but it is well worth it. And yes, absolutely. And if you have trouble, of course, our consultant, our training team, Karen Brown-Balford, is always ready to look at maps that you upload using the support button. And we're very happy to set up a one-on-one Zoom with any of our users who feel that, hey, I'm struggling in certain situations or something like that.
Thank you, Arnie. And for those of you that don't know, Arnie Snepfangers, he's the CEO of Eaglet Eye. So thank you for your help. Okay, somebody said, but do we need to fill the whole scleral bowl with artificial tears or just a few drops?
I'm not sure. I'm really sure I
I'm not
understand
sure
the
what they're
question.
asking.
But we, you know, when you fill the bowl, this is just talking about putting on a regular scleral, you want to fill the bowl up. You won't want any air in the bowl of the lens.
Okay, I see what you
Yeah.
mean. There's some confusion there.
Yeah.
Okay. If Dr. Andrzejewski, if you unshare your screen, I can start to wrap things up.
Sure.
You know, I do want to, you know, piggybacking off of what Arnie said about
Please.
talking about the consultants. The other thing, you know, the consultants at Synergize and the consultants at EyePrint Pro, which will always be there as well. I want to just make sure that you know how much experience we have with these incredibly diseased eyes, not just the fitting, but the disease process itself. And so, you know, when you're fitting a ScanFit Pro, you know, please feel that you can reach out and, you know, myself or one of our other doctors can really help you with the disease processes underlying the patient as well, because that's as important to manage as the scleral lens. You know, some of these patients are sick and they're difficult, and the more complicated you're able to fit, the more complicated your patients are going to become, and the more referrals you're going to get for very, very complicated people.
We can just take this time here too. Let me share my screen. We'll kind of jump to this last side. So we're really excited. In this fourth quarter here, we are partnering up with Synergize to become a distributor for us. So earlier in 2022 at GSLS, we announced that we have entered a distribution agreement for our ScanFitPRO product. So this partnership strengthens the synergized continuum of care for irregular corneas. We have a couple of them on the call today, so we're excited for them to join us and join us in our practice as well. So at the end of this webinar, if you would like to be one of the first practitioners to be able to offer the Synergized ScanFit Pro lens, we do have a new account survey form that you can fill out at www.synergize.com/ScanFitPro. And we're getting started here within the next week, so we're really excited about that. If you're a current ScanFit Pro practitioner, we will be reaching out to you about that transition. If you're a current Synergize practitioner and you're interested in the ScanFit Pro lens, definitely reach out to your sales representative, or again, just visit this website.
I'd like to say something about Synergize ScanFit partnership. Is I think one of the beautiful things is as a practitioner, you know, as me, I'm in my clinic at the University of Iowa, and I have patients, and sometimes patients end up being a little more complicated than I thought they were going to be initially, or they didn't react the same way I thought they were going to react. And by having an incredible company like Synergize with their entire continuum of care, it lets you move through products, you know, within the same company to really be able to provide all the care that your patient needs, even if you end up having to jump from one product to another product to get the result that you're going for. Their sales reps or consultants are absolutely incredible and really can help guide you through the process so your patients can get what they need without hurting your own brain, right? Without having to do a lot of returns and credits and things like that. So I'm very excited for this partnership, and I'm really excited for the things that we have on the horizon. So.
Yeah, and in doing so, you know, you can send them your raw Eaglet data, and you know they have a lot more consultants than we do at EyePrint. So, you know, it's a quick turnaround time. It's easy contact with the senior consultants, and ultimately better fits for your patient. So we're really excited for that.
Yeah.
We do have a question.
Yes.
So RC is asking, how long do you have a patient discontinue wearing a lens before you repeat scleral topography?
Yeah, that's a great question. Oh, do you want to take it?
Oh, go ahead. Go ahead.
Okay. So there's kind of been a couple different research studies done on this, and I think ultimately what's been found is 48 hours before we recommend taking it off. If they're a long-time scleral lens wearer and they have the time and ability to be able to be out of lens a little bit longer, that's probably ultimately going to be better. With the Eaglet data, because it's so detailed, we can see the impression of the old scleral on the data in our software, and in that case, you know, we'd have to bring the patient back in for rescanning, because ultimately we'd be designing the new lens over the elevations of the old lens, which is what we don't want. So yeah, about 2 days, 48 hours. If the patient has a hard time being out of their lenses, we suggest doing one eye at a time, you know, keeping one lens out for 48 hours, coming in to get the scan, and then scanning the other eye when they come back for the fit of that first lens. So.
And that goes really for any lens that you're fitting, not just the ScanFit lens. You know, even if you're doing trial lens fitting as well, if you don't have the patient discontinue the lens, you really are fitting the shape that their old lens was fit into. And so I have found just overall, I have better results, whether I'm using this product or even trial lens fitting, if we have the patients discontinue the lens prior to the fitting process.
So we just have a couple slides left. If another question pops up, I'll be watching for it. But again, the eye surface profiler, we've already heard a lot of comments about the device. We work with all specialty lenses. The first lens fit algorithms, which you heard Dr. Andrzejewski talking about, is a great way to get as close as possible to the actual first lens fit on your first design. Sure, you may have to make some adjustments, but the whole objective of using the ESP is to try to save you and your patient time and to get to a better fitting very, very quickly. It's an open platform. You choose the lens. Eaglet Eye has an academy, so we do a lot of education at Eaglet Eye, just like the people at EyePrint do a lot of education as well, which is very, very important. And then here's the contact information. So if you need to write something down, I'll leave the screen up for just a minute, but it has all the EyePrint Pro sites. But again, thank you. This is a really great. So Megan, Dr. Sent, Dr. Andrzejewski, really great information that you shared with us, Dr. Andrzejewski. Awesome cases. I just love these last minute people that jump into your office. They need something done very quickly. And that's the whole point. You know, we're all trying to work with these people and to take care of their needs. But those were great cases. And thank you for all the detail that you went into. And thank you everybody else for attending the program today. We really appreciate it. We hope it was valuable, that you learned something, and feel free to reach out to either us or the folks at ScanFit Pro. We'll get back to you. We'll get the answers you need. And, you know, we can do virtual demos at Eaglet Eye. If you're not used to the ESP or you're not familiar with it, you'd like to learn a little bit more, you can go to our website, fill out the contact form, and ask us for a virtual demo. We will be, I'm sure with EyePrint, we'll be at the Visions by Design meeting here at the end of September. But if you can't make that, feel free to contact us, and we'll be happy to get online with you and go through the slides and the images so you can see how the system works. And with that, I'll sign off again. Megan, Dr. Sent, and Dr. Andrzejewski, thank you very, very much.
Thank you.
Good
all.
night, everybody.
Thank
Bye-bye.
you.